Well, hi, everybody. My name is Garrett Schmidt. I am the managing editor for VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by Health Data Analytics Institute. And it is titled Managing Post-Acute Care, Harnessing Analytics to Improve Patient Outcomes. And we've got a great presentation for you today. Thank you so much for joining. A few items of note before we get started, some housekeeping stuff. Everyone's joined today in listen-only mode, traditional webinar format, so you don't need to worry about muting your microphone or turning off your camera or anything like that. We can't see you or hear you, but we do want to hear from you, and we are going to have some time for some Q&A towards the end. So if you have a question at any time during the presentation, you can ask it using your attendee module. There's a place for questions that you can submit questions there, and you don't have to wait until Q&A. You can ask it at any time, and we're going to get to as many as we possibly can during the allotted time. If we don't get to yours for some reason, don't worry. Someone will reach out via email afterwards and make sure that your question is answered. So even if we're wrapping up at the last couple seconds, go ahead and submit your question, and we'll get back to you. And then finally, we are recording the session today. So what's going to happen is when we're done, you're going to receive an email from either myself or my assistant Sarah, and she will get you over the link to the recording and also where you can download the slides from today's presentation. And you can share that with colleagues or review it or however, and we hope that you do. So finally, without further ado, I would like to introduce our speaker today, Mr. Josh Gray, and he is the VP of Analytics Services with HDAI. And also during the Q&A, Carola Endicott, who's the VP of Customer Engagement and Marketing, she's going to be helping us out with the Q&A. So I'm going to turn it over to you, Mr. Gray. Welcome.
Thank you very much, Garrett. Good afternoon, everyone. Good morning to folks that are calling in from the West Coast. As Garrett said, my name's Josh Gray. I lead analytics services at Health Data Analytics Institute, and joined here this afternoon by my friend and colleague Carola Endicott, who will help with discussion and questions. So what I'd like to cover today is the topic of post-acute care, which I think is a really critical area for any risk-bearing physician network. A lot of the data that we'll go through this afternoon focuses on accountable care organizations, ACOs, particularly ACOs participating in Medicare Shared Savings Program. But I think the principles really apply to any risk-bearing network, whether they be serving Medicare Advantage plans or commercial populations. This is actually, the materials you'll see today were derived from a presentation that I first gave at the National Association of Accountable Care Organizations, I think back in September. So let's jump in. First of all, I think it's important to start with definitions so we're all on the same page. The definition that I and my colleagues here like to use for post-acute care is all healthcare services provided to patients for 90 days following discharge from an acute care hospital. That's different from, what a lot of the kind of pay for performance contracts focus on, which, is often 30 days of either post-admission or post-discharge. I like the 90-day period because it really gets to the overall management of patients. And as you'll see from the data that I'm going to share, particularly with older patients, being hospitalized can often really be a life-changing event. And most people that are hospitalized are actually at elevated risk for at least 90 days after that event. So I prefer to go with that more expansive definition. So let's just start with some numbers to show how important a question or an issue this is. So in 2021, there were 33 million Medicare fee-for-service beneficiaries. There were 7.6 million, just over 7.5 million discharges from acute care hospitals. So a lot of patients, particularly older patients, do interact with the healthcare system through hospitalization, and therefore find themselves at this elevated risk trajectory. 28% of those people that were admitted were actually readmitted within 90 days. 29% were discharged to skilled nursing and rehab. So depending on what kind of sub-bracket you're talking about, like if you're talking about the 85 plus segment, becoming hospitalized is often truly a life-changing event, and many individuals don't go back, at least not at first, to live fully independent lives at home. It's also expensive, $211 billion if you just think about Part A and Part B in expense was generated by these Medicare fee-for-service beneficiaries. Again, that's not even including Medicare Advantage. And it's a dangerous time of life for people. So 13% of Medicare beneficiaries who are hospitalized actually died within 90 days of that period. So this is a challenging time. A lot of the physicians and leaders that we talk with describe sort of a lack of usable information. There's also more need amongst these people, both clinical needs, complex social needs, than there are people to take care of them. So it's really important for physician networks, health systems, really any delivery system to use the resources that they do have prudently. So, it is a reasonable question to ask, well, what does this compare to? What is the baseline? These are big numbers, but older individuals are at risk anyway. So what is it about the post-acute? How does the post-acute care period compare to baseline statistics? So these are the numbers for the post-acute care population. We just discussed the 13% mortality rate, 28% rehospitalization rate. The costs are about $28,000 per person per year. And you can see that that is much bigger than the same age population that wasn't hospitalized. So baseline mortality is about 1 point for individuals that aren't hospitalized and have Medicare coverage is about 1.4% every 90 days. 4.7% of them are hospitalized, and the cost is considerably less, about $2,600 compared to $28,000. So if you think about a multiple in the post-acute period, the mortality rate is 9 times higher, the rehospitalization rate is 6 times higher, and these folks are 11 times more expensive. So I would go so far to say that an accountable care organization, a risk-bearing network of any kind, you can't do a bad job with this population and still be successful. Success in general assumes that you're successful with post-acute care. So one of the questions that we wanted to answer is how effective are kind of population health entities in managing patients during the post-acute period. So we went in, and of the 33 million individuals that I've been describing to you, about 10 or 11 million are enrolled in accountable care organizations, 20 or so million are not, and we're not looking right now at the Medicare Advantage population. So to what extent are patients that are attributed to ACOs managed more effectively? And you can't really look at the raw data to answer that question. You need a very kind of rigorous approach to accounting for differences in acuity between the ACO population and the population of folks that are just in Medicare fee-for-service but are not attributed to an ACO. And what we use here at HDAI is what we refer to as a digital twinning methodology. And the way that works is we really, this is a methodology which we've spent at least 4 or 5 years developing, refining again. And the way it works is that we take each individual patient by patient, and find a group of digital twins for for each of these individuals. And then we match them up to comparable patients, comparable by definite demographic indicators. So age, sex, race, and ethnicity. Are they living in the community, or are they living in a skilled nursing facility? Did they have COVID in the last few years? Are they attributable to an ACO? What kind of area do they live in? And very, very importantly, what is their health history in terms of whether, how many times they've been in the hospital in the last couple of years, what DRGs and ICD-10 categories they've been placed into for their healthcare interactions. So, if we encounter 82-year-old Hispanic male with a history of congestive heart failure and diabetes, we'll find all of the individuals that share those attributes, and we will compare the outcomes. If we're trying to look at how effective ACOs are in managing admissions to a hospital due to diabetes, we will measure the actual experience of the people in a given ACO with the actual experience of their digital twins. So in contrast to many risk adjustment methodologies, which are really top down, looking at general patterns in the populations, our approach is really, kind of bottom up and meticulously matching individual by individual. Sorry for that digression. It's just really kind of important to understand how we account for differences in population and medical background. So do ACOs work in the post-acute care period? Well, you kind of start with the high level indicators. So mortality for individuals not attributed to ACOs, 13.3%. 12.8% are attributed to ACOs, so that looks good. Unplanned readmissions, a little bit lower, costs a little bit lower too. But we find that there actually are differences in acuity. People that are in ACOs are slightly less acute than people that are in not in ACOs. And so we really try to look at those statistics against what you would expect given our, kind of bottom-up digital twinning methodology. And when you do that, there actually is no difference in mortality for people in the 90-day period for people that have been discharged from acute care hospitals. Readmissions, slightly worse, about 0.7% higher. It's less than 1%, so you could argue that that's not very significant. Cost is a little bit lower, but only 1.1% lower when you account for all of this. So for people that really believe in population health, this is a little bit disappointing, but I think it's also not a sufficiently nuanced observation, because even if ACOs as a whole are maybe not changing the overall standard of care as much as one would wish, especially people that kind of believe in accountable care organizations, believe in population health, there are many ACOs that actually are setting a higher standard. So the next thing that we did is we took the 476 Medicare Shared Savings Program accountable care organizations that were active in 2021, and we sorted them by how effective they are in managing mortality, unplanned readmissions, and cost. And even if ACOs as a whole aren't performing as noticeably better than overall Medicare fee-for-service, many of them are. The top 10% of ACOs, so say the top 50 or so, top 48 ACOs, are actually lowering the adjusted mortality rate by more than 10%, 11%. So they are kind of operating in a way so that everyone, 10% fewer people in this high-risk 90-day post-discharge period, 11% fewer people are dying during that period. They are achieving 9% fewer readmissions. They are eliminating about 11% out of the cost equation. Similarly for the top quartile, so these are 100-ish ACOs, they too are setting a higher standard, 5% lower mortality, 4% fewer readmissions, 7% lower cost. So ACOs as a whole might not be, kind of absolutely blowing it away in terms of the outcomes you would care about, but there are many, many ACOs that in fact are delivering a better, a safer, a more cost-effective standard of care. And the real question is, what are they doing differently from standard ACOs? And after talking to a lot of ACOs, and my colleague Carola and her team have interacted with a lot of partners that we've been working with for the last couple of years. We think that the more effective ACOs are doing at least two things to achieve better outcomes and to differentiate their performance. The first thing is that they're very effective and very systematic in both identifying high-risk patients and managing them before they're readmitted, managing their chronic diseases more effectively. Again, you can't do that with everyone. So they're good at identifying the people that most need care and applying their limited resources to doing just that. The second thing is no network exists in a vacuum. Okay, many providers, from primary care doctors to physician's assistants, nurse practitioners, and in our case in particular, skilled nursing facilities, which is what we'll dive a little bit deeper on in a minute. You need to be working with the right partner. So it's really those two things. We'll save a few minutes at the end to just look at a partner that we've been working with a lot for the last 18 months and look at some of the approaches they've been taking to achieve great outcomes, particularly their approach to case management. So let's start with that first bucket. So what do these ACOs do to identify and manage high-risk patients? So let me set the stage for you here. This is, kind of an output from our predictive modeling. So what we've done here is we've applied our prediction models. So we have, prediction models for emergency room visits, for mortality, for all kinds of things. Here, we've been sharing our models for readmission risk. And at the bottom, we have divided the 30 million Medicare fee-for-service beneficiaries into 20 bins. So bar number 20 at the far right there is the 5% of patients that we predicted at point of discharge in our models would be at greatest risk of readmission. So we went back to 2021 and we put all of the hospitalized patients into each of these bins, and we compared that to the actual performance. And so you can see the results here. The bin number 20, so the 5% of patients that we thought were at greatest risk of readmission at discharge accounted for 12.3% of all of the people that were discharged. Bin number 19 accounted for another 10%. So you take the top quintile, the top 20% by predicted risk, and they actually accounted for just under 40%, 39% of all readmissions. And I think this is a good, example to illustrate the proposition. It's not perfect. Not all of the people that we predicted were at highest risk or readmitted, but they were at much greater risk. And there's another way to look at it. This is telling you what percentage of all readmissions are accounted for by each risk bin. Another question is, what is the readmission rate for each risk bin? So again, I'll just start with the exaggerated example. So the very top 5% at risk, 67% of those individuals, so 67% of the individuals that we predicted would be at highest risk at point of discharge actually were readmitted over the next 90 days. You look at the next bar number 19, 54%. In fact, you look at the top 20% by risk, about 50% of them were actually readmitted. And for those of you that are more, kind of familiar with probabilities, that hit rate, you identify high-risk people, half of them actually experience the event that you're concerned about readmitting. That's high fidelity. That's a high, a high hit rate. Not perfect, but again, if you have a limited number of case managers, you really don't want them calling up people that aren't, likely to be readmitted. You really want them to focus on the highest risk people, and you can't always do that. What our partners have shared with us is you can't always do that intuitively. You really need to take the numbers, their age, their sex, the cumulative experience of their past interactions with the medical system into account to do that. I'll tell you, let's look at another phenomenon. Let's look at mortality risk. So again, this is the percentage of people who actually died based on how risky we thought they were, what their risk of death was at discharge. So the top 5% of people, this has been number 20, the bar at the far right, the 5% of people that we predicted would be at greatest risk of mortality, 30% of them actually died within 90 days of being discharged. Next bin, 17%. 12%, 9%, et cetera. Some of these people were kind of obvious. They were people that obviously needed hospice, were transferred to hospice. Many others, weren't. The key was in their medical histories. And so if you take the 20% highest risk patients, you will count for really about 2/3 of deaths. Again, just as we did in the readmissions exhibit, the second question is, what is the hit rate? How many people in each of these bins actually passed away within 90 days? The highest risk bins, the top 5% by risk was 77%. If you look at the top 4 bars, which again is the top quintile, the top 20% by predicted risk, their mortality rate was 40%. So again, predictive analytics in the current environment where more of the industry is moving towards risk-based, value-based care, where resources are very limited, especially after COVID, especially after the so-called Great Migration, you need to make sure that your staff are focusing on the people that need it the most. So I don't know about the folks on the call. I personally wasn't, I have more of a kind of operations background. I wasn't really trained very deeply on probability and predictive analytics. I've had to learn it. Maybe many of you are in the same position. And so there's an interesting question like, how do you think about this? How do you think about predictive models? How do you think about developing your own if you're a large organization or partnering with a vendor if you're not? And I like the concept of signal enrichment factor, which is, for a high-risk group, and here we've somewhat arbitrarily chosen the top quintile. The reason we do that is many of our clients can, come close to managing the top 20% by risk of their population. They can't do much more of that in general. So if you look at mortality, again, as we reviewed, the baseline mortality rate's about 13%. The top quintile is 43%. So that's an enrichment factor of 3.4x for mortality. Similarly, for readmissions, it's 1.9x. And as I actually think predictive analytics is a very, very powerful tool. And as you think about deploying these tools in practice, I think this is a good framework to think about the tools that you want to adopt. Another thing that we've thought a lot about is what you do about these patients. Okay, and we tried to start pretty basically. And it seems to me that one of the things that you want to do as a proactive, anticipatory, population health oriented accountable care organization or health system or physician network, what have you, is see the patients that are at highest risk pretty quickly after they're discharged. And so we began by looking at patients that had no adverse events within the 90 days after discharge, but they were, some of them were still at high risk. And you know what? It takes a while to see these patients. For all non-ACO patients that were discharged from a hospital, so again, these are several million people, on average, it took 18 days, 17 and a half days for these individuals to be seen by a physician. That strikes me as a pretty long time. The highest risk patients, and by that I mean the highest risk quintile, so the 20% patients at risk of being readmitted or dying, they weren't seen a lot sooner, 15.4 days, and they're seen a little bit faster by accountable care organizations, but not a ton faster. They were seen at about 13.4 days. Those are patients that didn't have an event. On the right-hand side, we have reproduced this for patients who did have an event. It's a little bit more complicated because some of these patients were seen because something happened to them, rather than being seen before something happened to them. And on average, it took these, and it's still, these are patients who died. These are patients who were readmitted. Not a huge difference between ACOs and non-ACOs, as you can understand as you scan left to right. But it still took these people 9 or 10 days to be seen. And the people that were at highest risk weren't seen a lot quicker. I think we can do better. And in fact, for me, the most noticeable, in some ways the most disturbing aspect of this, were that 39% of patients, again, this is all Medicare fee-for-service patients, whether or not they were in an ACO, 39% of people who died or were readmitted did not even have an E&M visit, did not have an evaluation and management visit by a physician, a nurse practitioner, or physician's assistant before the event. So I think this is a way in which, if you use predictive analytics, one way that you can apply that information, at least you can understand who's at higher risk, and at least you can make sure they're seen rapidly. Not all of them will be kept out of the hospital, but at least you'll have a much bigger chance. This is a similar way of making the same point. And so again, this is the same framework. We have binned the population into 20 groups by their risk of readmission. The dark blue bars show you the percentage of those individuals that were seen in the first week. If you add up the blue bars and the greenish bars, those are the percentage of people that were seen in the first 2 weeks. So of your top, your very top 5%, 65% of them were seen in the first 2 weeks, only 43% in the first week. But what I really want to show you in this graph is if you scan left to right, except for the very lowest risk people, high risk and low risk people are really not treated that differently. It takes about the same amount of time to treat an individual if they're at the 96th percentile of risk as it does if they're in the 40th or 50th percentile of risk. So in essence, service delivery is not really anchored to the inherent risk of the patient. I'm sure well-meaning clinicians are using their intuition. I'm also sure that their schedules are impossible and they're backed up. But if you're thinking about intentional service delivery, I think that kind of rearranging things so that you see the frailest, the most at-risk people the soonest, so you can maybe keep them out of the hospital, is worthy of your attention and worthy of your efforts. So we asked ourselves, who's doing this? And a colleague, a research colleague, and I literally spent an afternoon skimming the data. I don't think we got to every ACO in the country, but we got to most of them. Very, very few ACOs are speeding up their process of seeing at-risk people. We did find one California ACO that I think is doing a decent job, not perfect, but decent. So if you look at the top quintile by risk, 62% of those patients are being seen within a week. That's way better than baseline, which is more like 42, 43, 45%. The lowest risk quintile, only 37% of them are being seen within a week of discharge. I'm sure, you know, some of them are in good comparative health. They're just much more involved in their own care. So this ACO isn't perfect, but it's made a lot of progress, and I think it's a good example of, you know, at least taking steps to improve your service delivery. So that is it for identifying and managing high-risk patients. Again, Carola will be collecting any questions you have, so if you have a question about that, please note that. If you've taken measures to use predictive analytics to be more active for your high-risk patients, we'd love to hear about that. I'm sure other people in the car would love to hear about that as well. And, you know, the next thing I really wanted to talk about is what ACOs, what risk-bearing provider networks are doing to select high-performing post-acute partners. They can't do everything themselves. They need to be working with the, you know, the right organizations. All but the largest health systems don't own every component of the healthcare value chain. Even large healthcare systems need to partner with, you know, with independently operated organizations, whether they be small or part of another health system. I'll use the example because it's really important and the data availability is excellent of skilled nursing facilities. So most of you are probably, you know, familiar with the CMS star rating system for SNFs for skilled nursing facilities. You know, there are many factors that go into it, like staffing and, you know, reports of violations to the health department and things like that. There are stars assigned to a lot of skilled nursing facilities. It goes anywhere from 1 star to 5 stars. There are just under 6,000 skilled nursing facilities in the United States that had at least have at least 50 Medicare fee-for-service patients using those facilities in a typical year. And one of the things that we like to look at is actual to expected mortality rates by skilled nursing facilities. And that's what you have here. So the thick bars in the middle of these charts are the overall indexed mortality rate for the hundreds and hundreds of skilled nursing facilities that have 5 stars, 4 stars, 3 stars, etc. And all of these green bars going across give you a sense of the proportion, the number of SNFs that have higher or lower mortality. So you'll see that there are some 5 and even 4 star skilled nursing facilities that you know, kind of line up at 0.5. Those institutions literally have 90-day mortality rates, and the anchor date is when a patient was admitted to the skilled facilities. So 0.5 means that their mortality rate is 50% lower than would be expected. Now, if you look across, you can see that the dark bar, which is really the average mortality rate, is slightly lower than what is expected overall. So it's slightly below 1 for a 5-star facility. It's slightly above 1 for a 4-star facility. But the real key is looking at the distribution. There are many you know, green bars associated with the 4-star skilled nursing facilities that have a lower mortality rate than many of the bars that have the 5-star rating. And so I think the kind of take home is that just choosing a skilled nursing facility based on the number of stars is an extremely blunt instrument. There are many 4-star skilled nursing facilities that have lower mortality rates. They also don't have not showing the data here, but they also happen to have lower readmission rates, lower costs than 5-star facilities. So in a perfect world, you'd really want to get a lot deeper to understand not just do they have 4 or 3 stars or 5 stars, but how is the individual facility performing on metrics that you really care about. And just to I realize that this is a pretty abstract exhibit, so I tried to make it a little bit boiled down here. And if you look at, I'll just kind of steer you to the right-hand side. So you're looking at actual mortality compared to what you would expect. And the median 5-star skilled nursing facilities you can see in the medium row on the right is 3% below what you would expect for a 5-star skilled nursing facility, 4% above what you would expect for a 4-star facility. But the point is that it is better to go to a top quartile 4-star facility than a average 5-star facility. For a top quartile 4-star SNFs have mortality rate of 14% below what you would expect. An average 5-star facility has, as I just said, 3% below. A bottom quartile 5-star skilled nursing facility actually has mortality rates 15% above what you would expect. So again, you really need to go well beyond the overall ratings. The other thing that we've noticed, and this is a data set that we generated working with one of our partners, we fuzzed out the skilled nursing facilities on the left, but we live in Boston, and Carol and I both have parents, and our parents need the hospital sometimes, and I make sure my mom goes to a very different hospital for orthopedic needs than for cardiac needs, because some hospitals are great at orthopedics, maybe not as great for cardiovascular services. And if you skim across, what we've done here is for each skilled nursing facility, and this is not mortality, this is hospital readmission rate. So the patient goes to the skilled nursing facility, but has to be readmitted back to the hospital, in this case within 30 days. Not every skilled nursing facility is comparably proficient at every diagnostic group. So let's take the whatever the second to last skilled nursing facility is here. They do a great job at infectious disease. Their readmission rate for infectious disease is 0.69, so about 31% below what's expected. They don't do a very good job on circulatory system admissions, where the readmission rate is 43% above what's expected. Interestingly, the top skilled nursing facility here, it's exactly the reverse. They do great at cardiovascular, not so well at infection. So again, in a perfect situation, you would be doing what you can to encourage. I realize the level of control here is far from perfect, because patients and patients' families to a greater or lesser degree are sometimes driving the boat here. But at least, it behooves you, if you can, to give the families the information, not just about which 5-star skilled nursing facility is better than other 5 skilled nursing facilities, which 4-star facility is particularly good, but you might make different decisions based on what's going on with your patients during, this kind of very high-risk period for them. So I think, again, those are the top 2 imperatives that we see in our experience of accountable care organizations that are doing a great job on this post-acute period. I'd like to talk a little bit now about one of the ACOs that we've been working with. I actually believe a couple of the leaders are on the phone here today, but I think we've kept the data somewhat anonymous. So this is an accountable care organization that had invested heavily in case management, and they believed in case management. They're also, kind of a highly analytic program, and they want to understand how effective their investment was, how effective this part of the delivery system was, in part because they want to know how to improve. And this was in most ways a very encouraging analysis, I thought, because they took working with them, we took all of the patients that were being managed by their RN case managers in a particular year. And we wanted to know, are they lowering the readmission rate? That was one of their main goals, to control the readmission rate for people in their accountable care organization. And it was great news. The expected rate of the digital twins attached to the people that they were case managing was 20.7%. The actual readmission rate for these case managers were 16.9%. So they're actually lowering the readmission rate by just under 20%. So, you know, readmissions are super expensive. So this is a great return on the investment. The other, you know, kind of amazing thing was, you know, if you have an ethic of continuous quality improvement, you want to keep digging down deeper. And so the physician leader of this organization, the leader of case management, really wanted us to look at the performance of each individual case manager, and we did that. And you can see that there was a fair amount of variation depending on which case manager you saw in terms of how effective they were in lowering the readmission rate. In particular, Nurse E, who was, you know, kind of anecdotally considered to be an excellent case manager, had an expected readmission rate of 19.6% and an actual readmission rate of 12.5%. So she was lowering the readmission rate by more than a third, which raises the question: what might she be doing differently that her colleagues would want to understand? And so, you know, I think this was great information. This is not a program that rests on its laurels at all. Very back of the envelope, it remains to be seen, you know, how realistic this is, how achievable it is. But at least in terms of applying the numbers, you could imagine getting even better than the 19% reduction in readmissions. So what if they chose to case manage individuals that had an even higher readmission risk by, you know, for example, using the readmission risk predictors that I walked you through earlier in the presentation? If they just applied the same effectiveness to higher risk patients, you know, we estimated that they're currently reducing the number of readmissions by very close to 60. We think that could get up to 100 if all case managers were performing at the level of case manager E. That could get even higher. We think, at least in principle, they might be able to get as high as 150 or a little bit more. The point is, even getting halfway there would be you know, they're doing great already, would be, I think, a huge accomplishment and a huge victory. The other thing that we have, an insight we've generated working with this ACO partner, is going back to the issue of skilled nursing facilities. And so, you know, we studied a few health systems, and health systems actually, not untypically, have patients that, when they're discharged, go to a very large number of skilled nursing facilities. And in this case, over, I think it was about a 3-year period, patients had left the hospital and gone to, you know, literally 100 skilled nursing facilities. Some of them were high volume. We somewhat arbitrarily define high volume as 11 or more admissions. There were 12 skilled nursing facilities that had 11 or more admissions, 89 that had fewer than that, and about 60% of the admissions, so about 300 out of 500 or so readmission individuals, went to those high volume SNFs, those high volume skilled nursing facilities. The expected mortality for those facilities was 11.3%. Actual mortality was 6.5%, which is amazing. So this was a system that was excellent at choosing effective skilled nursing facilities. Less encouraging are the people that went to low volume skilled nursing facilities, or a lot of them. There were 200. This is just Medicare fee for service. There are other commercial, other Medicare Advantage individuals. Expected mortality of 11%, actual mortality of 13%. So they come in at 17% above what is expected. Put another way, the mortality risk for patients that were going to high volume SNFs was only half the mortality rate of those going to low volume SNFs. I'll tell you, I unfortunately faced this situation with my dad over the last year. I had to find a skilled nursing facility for him. Thank God he's done very well, but I didn't have anything like this level of information at that time. It was a real black box, and I think we can do better. So, you know, I think this was nicely summed up by the chief quality officer of this health system that, you know, has this very large affiliated accountable care organization. We've been working closely with both of them, and what this gentleman said was, we don't have the data to tell SNFs what they need to do to better help patients. It's ultimately up to the patient. But if I can tell them that they're 5 times less likely to die at a particular SNF than the SNF that they might otherwise choose, I think they'll make the right choice. This health system, this ACO, cannot mandate that a patient or a patient's family choose a particular provider, but they can give them the information. And I'm at least optimistic that some families will make a more informed decision. So that's really what I wanted to cover with you this afternoon. Again, post-acute care is just a really, really important segment of the healthcare value chain. It should be, what I've learned from the people that are doing this well, is that it should be managed intentionally and effectively, and it can be, and it is by many organizations. I think predictive analytics has a role to play, not to tell you what to do, but you know, out of respect for the limited resources you have, at least where to you know, where to direct them. So that's what I had to say in terms of prepared remarks. I see that I think we have 12 minutes left. If anyone has questions, again, please type them in the chat bar. And thank you very much for coming to the session and for your patience in sitting through that material.
Thank you so much, Josh. I really appreciate that. And actually, we do have some questions. There are a couple of themes. There's a couple questions related. People have picked up that we do predictive modeling. Mm-hmm. So there were a couple of questions on how do we actually create those models, and then a couple of questions on twinning, sort of related then to that. But if you could just give maybe a short thumbnail on how do we build models? What's the data we use? How, yep. You know, just a little bit of background.
Thank you for the question, whoever asked that. So I'll give you at least a thumbnail sketch. If you're still interested, let us know, and we can have a follow-up call with some of our technical staff. But we are one of a handful of private companies. So we're a startup. We're located outside of Dedham, Massachusetts. We've been a company for about 4 years. Carol and I both joined when I think we had about a dozen people. We're now up to 60 or 65, I think. But we have seats on the CMS Virtual Research Data Center, which is a huge privilege, and it's a great data asset. So the VRDC has claims for tens of millions of people that have or had Medicare that really go back, I think, till 1998. So it's a couple of decades worth of data. It's every claim, Part A, Part B, Part C. I don't think we have Part D claims. And what we do, so I should have said, all of our models are based on claims. We're just beginning to harness the large language models, Chat GPT-4 and the like, to try to mine data from clinical narratives in electronic medical records. But again, what we'll do is we'll, you know, a lot of this really comes down to acquiring and generating information at an appropriate point of the care cycle. So we will gather claims for ACOs. There's a kind of a data feed called BCDA where we get ACO claims within a week of the occurrence of the service. We will take a patient, we'll filter it into our algorithms in a completely de-identified and secure way. And we will generate their risks. I think we have 220 or so outcomes. So the risk of death, the risk of readmissions, not just the risk of readmissions, but readmissions for, for diabetes, for congestive heart failure, the risk of a fall, et cetera, et cetera. So we could, calculate the risk of two different things happening, and we can develop additional outcomes if we haven't already. We're set up to do that. We generate these outcomes generally for 7, 14, 30, 90, and 365 days, and are pretty flexible on time period. Another application is not just applying our models to an individual, but to a panel. And so you might be, an executive leader, a physician leader in an accountable care organization. You might have a program, a fall reduction program, and you might want to reach out to the 10% of individuals at greatest risk of falls. And so we can help you data mine and bring up a list of those individuals. If you wanted to further refine that and bring up a list of individuals that were at risk of falls and also had a history of osteoporosis, so a fall would be more likely to be catastrophic, or a list of individuals that had osteoporosis and dementia, so a fall would be physically catastrophic and also catastrophic from a social point of view. We could do that as well. So I realize that's a somewhat high level answer, but again, Carol and I would be honored to follow up with anyone that wanted to get deeper or wanted to ask specific questions about how these predictors are deployed in practice.
Great, and actually that you answered another question that came in about can we predict patients who would benefit from palliative care, which is something we do actually work with that. We have a predictor on likelihood to enter hospice in the next 90 days. And we do have ACOs, some on this call, actually using these predictors to try and be more proactive, get ahead of patients who otherwise maybe end up on hospice for 2 or 3 days and don't get the full benefits of those services and the conversations that come with that. So thank you, Josh. I think the next question was about, again, it's related to this, which is, so we talked a lot about readmission in the slides. Somebody wanted to know if we can actually predict, is readmission something we can predict at the patient level?
Oh, no, absolutely. So what we typically endeavor to do, and this would involve a much longer discussion about interoperability and how we embed our predictions. So for example, we're in the process of embedding our models within Epic environments, but no, absolutely, we will identify a patient, we will look up her medical history, we will basically in real time match her up with people that look like her from a from an age perspective and a health history perspective. So she will go home, and our clients will know there is a 47% chance that she will be readmitted within the next 30 days. It gets that specific. we've also done a lot of, actually Carola has led this work to, you know, there's a whole nother question about how this information is fed back to clinicians and case managers, population health managers. And Carola's team has worked very hard to distill the history and the risk profile so that population health nurses and physicians, if they're interested, can understand the risk profile. So this person might have a fall risk or a readmission risk that is connected to her dementia or her congestive heart failure. And you know, we have a very deep philosophy of not prescribing clinical behavior. We don't want to tell a nurse to tell a doctor what to do. We want them to have the information that they need to make the correct you know, decision. We think that clinicians usually do the right thing. They don't always have the perfect information at hand, and they're not always spending as much time as the patient could benefit from the highest risk patient. So that's our philosophy on individual patient prediction and risk assessment.
And I think, Josh, you mentioned in the presentation that many of these care management teams, they're not staffed to touch everyone.
Yeah.
So where do we focus? And sometimes we have ACOs we work with who don't want to focus on the top highest risk patients. They want to focus on that next tier down, those rising risk patients. One of the physicians we were on a call with the other day called them ghosts, patients who don't necessarily show up on the list that they're used to seeing, but we can identify the opportunity to intervene with them and give some clues as to what might be driving that risk. So we're just about out of time. We got a couple of people asking if we could offer SNF performance for their local markets, similar to what Josh was showing at a more national level. And yes, we have this data. The twin-based performance analysis, we have that based on cost readmissions, length of stay, and a number of other factors. So if that's of interest, we'll have the slide. We'll have our contact at the end. And I'm just so sorry. There's a couple of other questions people had about twinning. We can get back to you separately, and we'd be happy to do that. And as Josh offered, we'd love to talk to anyone who wants to drill down deeper into these topics. So I think with that, I'm going to pass it back to Garrett and maybe advance the slides and let Garrett lead us out.
Great, great. Well, first of all, thank you both so much. And Josh, that was a fantastic presentation. And thank you, Carola, for helping with the Q&A. I know I got out a lot of it. But yeah, in closing, I just wanted to encourage everyone on the webinar here today to visit vbcexhibithall.com and stop by the HDAI exhibit booth there. They have a virtual booth that you can kind of do a deeper dive on some of the things that they're doing in the value-based care space. You can interact with their team, download some resources, see some interviews, that kind of thing. There's a lot of great materials there. So stop on by to VBC Exhibit Hall and check that out. And then finally, if you would like to reach out to Mr. Gray or to Carola or any of the HDAI team, you can do so if Josh, if you'll go to that last slide. And there you go. So we got some the contact information there for them. Or if you would like to reach out to me, I'm happy to put you in touch and facilitate an introduction as well. But thank you all again so much for joining us today. I hope this was a fantastic and informative presentation for you, as I know it was for me. So I hope you have a wonderful rest of your days. Thank you so much. Bye-bye.
Thanks, everybody. Thanks, Garrett.
Thanks, everybody.